This is our presentation on amyotrophic lateral sclerosis, or ALS. The group members are Jordan Anderson, Taylor Bird, Chase Castles, Nicholas Howell, Ashley Malthus, Jasmine Thomas, Ashley Winden, and Bailey Lippery. The demographics of ALS: it is classified as a rare disease, but it is the most common type of motor neuron disease in adults. ALS primarily affects adults between the age of 40 and 70, and it is 20% more common in men than it is women. Within the United States, non-Hispanic whites are approximately twice as likely to develop ALS as African American and Hispanic populations. Some of the risk factors of ALS are linked to lifestyle and environmental factors. Patients can have a history of physical trauma or injury, like skeletal fractures, head trauma, severe electrical injuries, or burns. Previous exposure to neurotoxins is also a risk factor, like fertilizers or pesticides. Heavy metals like lead and mercury and exposure to those can be a risk factor for ALS, and exposure to organic solvents like cleaning solvents and degreasers, alcohols, and ketones. The etiology with ALS: so worldwide, there's around 1 to 2.6 cases per 100,000 people that are annually diagnosed with ALS. And then the prevalence throughout the world, around 6 people out of every 100,000 throughout the world have ALS. In the United States, the incidence, there's about 1.6 new cases per 100,000 people every year. And then the prevalence in the United States, 5.2 people per every 100,000 people living in the United States are diagnosed with ALS, which that is a total of 16,583 cases. The pathophysiology. So, amyotrophy refers to the atrophy of muscles. As the cranial and spinal motor neurons in the brainstem and the ventral horn of the spinal cord degenerate, the muscle fibers become denervated. Lateral sclerosis refers to the hardening of the ventral and lateral columns of the spinal cord. The corticospinal neurons in these areas degenerate, and they're replaced by fibrous astrocytes. As the axons degenerate, collateral branches of surviving axons and surviving area will sprout and reinnervate the denervated muscles, and this is just a way for it to compensate for that motor loss. ALS can be sporadic, meaning that you don't have to have any family history, but it can also be inherited or gene mutations, or it can be developed through a complex interaction between the molecular and genetic pathways. The clinical presentation and progression. So typically patients will present with slow, progressive, asymmetric muscle weakness and atrophy, and it will also present with hyperreflexia. Typically, people with ALS will not present with sensory dysfunction, bowel or bladder impairments, or abnormalities of any eye movements. Because of this, one of the more recent technologies that have been shown to help patients with ALS is eye tracking technology, so that the patient can communicate by just looking at a keyboard and typing out what they want to say, so that they'll still have that quality of life to be able to communicate with their loved ones or peers. 70 to 80% of patients' symptoms begin in the extremities. So it'll start distally, and then as it progresses, it'll become more proximal. And studies have shown that continuous progression of the disease is likely to occur, meaning that it will start distally and it'll slowly progress at each stage as it comes proximally from the extremities into the trunk. Diagnosis. There's no definitive diagnostic tests or biological markers. More recently, there's been a revised diagnostic criteria, which is the AWAS schema. The AWAS schema uses electrophysiological and clinical signs of lower motor neurons to detect loss and reinnervation. Electromyographic studies are the most important diagnostic test. It reveals signs of active and chronic denervation. Electrophysiological, muscle biopsy, and neuroimaging studies are also used to diagnose ALS and rule out other diagnoses. And another way diagnosis is made is through clinical findings of progressive weakness with upper motor neuron and lower motor neuron lesions, which would be in the brainstem, cervical, thoracic, and lumbar regions. So it is really important clinically to notice these signs so that you may have your patient go and get more testing done, maybe have the electromyographic studies or the muscle biopsy so that they can confirm and rule out other diagnoses. Prognosis. So ALS is a progressive disease, and there is rare remission or stages of disease plateau. So oftentimes this disease is just continually progressing and continually getting worse, and it's really unfortunate for patients because there are no stages where the disease will kind of level off and they'll stay in a certain stage, or there's no chance for real remission. The disease will just continue to progress. And another unfortunate prognosis with this is that death occurs approximately 3 to 5 years from the time of the diagnosis, and it's primarily due to respiratory failure. So, as the disease progresses, it'll come more proximally and it'll eventually start to affect the respiratory muscles, and it'll be really hard for patients to breathe, and that is the main cause of death in these patients. But the outlook can change based on positive and negative prognosis factors. So, if patients get really good care and they had really good health before being diagnosed with ALS, it is possible for them to live past 3 to 5 years. Steve Gleason, the former Saints player, he has been living for 13 years with this disease. So there is a possibility that patients with this disease can have a better prognosis, but it does take a lot of care for these patients to be able to survive longer than that 3 to 5 years. So now that we have an idea of what ALS is, we have some questions. Question 1. Which of the following clinical signs would best indicate upper motor neuron involvement in a patient with amyotrophic lateral sclerosis? A. Fasciculations and muscle atrophy. B. Flaccidity and hyporeflexia. C. Spasticity and hyperreflexia. Or D. Muscle atrophy and absent reflexes. So you can either pause the video, or if you know the answer, we'll go ahead and get to it. The correct answer is C. Spasticity and hyperreflexia. ALS affects both the upper and lower motor neurons. So clinical signs such as plasticity, hyperreflexia, and muscle atrophy are all indicative of lower motor neuron involvement, and the only answer here that shows upper motor neuron involvement is C, spasticity and hyperreflexia. Question 2. Which of the following physical therapy interventions is most appropriate for preventing joint contractures in a patient with advanced ALS who is now non-ambulatory? A. Active range of motion exercises. B. Passive range of motion exercises. C. Global strengthening exercises. Or D. High frequency E-stim. Again, you can pause the video, but the correct answer is B. Passive range of motion exercises. In advanced ALS, patients lose voluntary muscle control, so passive range of motion is essential to maintain functional range of motion and to prevent secondary complications like contractures, which severely affect the quality of life for these patients. Active range of motion and strengthening exercise is not really feasible for patients with advanced ALS because their motor neurons that control voluntary muscle movement are severely damaged, leading to profound muscle weakness and atrophy. So by doing active range of motion, they really won't be able to get that. So also global strengthening exercises would not be a good choice for that same reason. And then high frequency E-stim is not indicated for patients in this population. Question 3. A 56-year-old male with early stage ALS presents with mild right hand weakness, muscle fasciculations, and increased fatigue during daily activities. His goals are to maintain his independence and minimize functional decline. During your evaluation, you notice difficulty with fine motor tasks such as buttoning his shirt. What would be the most appropriate intervention strategy for this patient? Prescribe a high-intensity resistance program targeting hand muscles to improve fine motor skills. Focus on functional strengthening exercises and energy conservation techniques. Implementing a high-frequency electrical stimulation program to improve muscle strength and reduce fasciculations. Or encourage prolonged aerobic exercise to maintain cardiovascular endurance. Again, if you want to pause the video. The correct answer is B. Focus on functional strengthening exercises and energy conservation techniques. So in the early stages of ALS, functional strengthening exercises can help maintain independence without overloading the muscles, and energy conservation techniques are essential to prevent fatigue. You would not want to do high-intensity exercise programs or high-frequency electrical stimulation because you could cause overwork weakness due to the compromised motor neurons in these muscles. And cardiovascular fitness is important, but prolonged aerobic exercise may also increase fatigue and is not a primary concern right now. Question 4. A 58-year-old female with ALS has progressed to the point where she can no longer walk independently and relies on a wheelchair for mobility. Her primary complaint is discomfort and spasticity in her lower extremities. What would be the most appropriate physical therapy intervention to manage her spasticity and improve her comfort? A. Use of prolonged passive stretching followed by positioning in a wheelchair with proper supports. B. Implementing of aggressive strengthening exercise for lower extremities. C. Application of cryotherapy to lower extremities before initiating range of motion exercise. Or D. Prescription of a standing program to reduce spasticity and improve weight-bearing tolerance. So you can pause the video. So the correct answer is A. The use of prolonged passive stretching followed by positioning in a wheelchair with proper supports. So this can help manage spasticity and improve comfort due to ALS, especially in the advanced stages. Often, these patients will lose their ability to actively stretch their muscles, and without regular passive stretching, muscle shortening and joint contractures are more likely to occur. Maintaining joint flexibility and muscle length through passive stretching is crucial for maintaining comfort and functional position. You would not do aggressive strengthening exercises because they are not appropriate for ALS patients as they may exacerbate spasticity and fatigue. Cryotherapy may temporarily reduce spasticity, but it is not a long-term solution, so it was not the best answer. And a standing program can be beneficial for maintaining bone density and circulation, but its effectiveness in managing spasticity is less immediate compared to stretching and positioning. Last question, question number 5. A patient with ALS presents with spasticity in the lower extremities, especially during gait activities. You are planning to use a functional mobility intervention. Which of the following would be the best approach to manage the spasticity and maximize the patient's mobility during functional tasks? A. Perform static stretching of the lower extremities prior to functional mobility activities. B. Implement dynamic stretching and gait training with assisted devices to reduce spasticity. C. Prescribe high-resistance strength training exercise to counteract spasticity. Or D. Use prolonged icing technique to inhibit spasticity before gait training. I'll give you a minute to pause. And then the correct answer for this one is B. Implement dynamic stretching and gait training with assisted device to reduce spasticity. So the reason for this is dynamic stretching and functional gait training with appropriate assisted device can help reduce spasticity and improve mobility by promoting more normal movement patterns. Static stretching alone may not address functional limitations, so that would not be the correct answer. High resistance strength training is contraindicated in ALS due to the risk of exacerbating spasticity and muscle fatigue. Prolonged icing may temporarily reduce spasticity, but it does not address functional mobility directly. And that concludes our video. If you liked the video, please like and subscribe. It will really help out our channel. Thank you.